Hello, I think you'll enjoy this video about stabilizing a mandibular denture that's been secured by small diameter implants. Remember, implants do not completely stabilize a denture because when you're placing implants most of the time with a removable denture, the implants are in the anterior part of the maxilla and the mandible. So the fulcrum point is across the anterior part of the maxilla and the mandible. So if somebody eats something sticky or like carbohydrate, what have you, on the back teeth, and it squishes into the teeth are going to lift a little bit. Occasionally, if somebody bites on the left or the right, the other side will torque just a little bit because of the fulcrum. So in this patient's situation, he was complaining that his mandibular denture, which had been stabilized by small diameter implants, was moving a little bit when he chewed food on one side or the other.
Are you feeling stuck? You know you have more to offer and you can elevate higher in your dentistry practice, but you just don't know how to do it? Well, great news. DentistryMasterclasses.com is here for you. At DentistryMasterclasses.com, Dr. Cutbirth is offering his greatest work and his best cases. Here's everything included when you subscribe to DentistryMasterclasses.com. You will get incredible comprehensive cases not seen in Dental Minute videos, an organized library of all the Dental Minute videos, and the Dentistry Masterclasses, comprehensive cases for study and reference. You will get before and after pictures of Dr. Cutbirth's fantastic restored cases. And guess what? All of this is $40 a month. That's right, $40 a month. This is an opportunity you cannot miss. Go to dentistrymasterclasses.com and subscribe today.
So what I'm doing to stabilize the mandibular denture is I'm adding a small diameter implant, a 2.5 millimeter, in the first molar area. Before you commit to doing that, I want to measure with a periapical radiograph and be sure there's enough vertical bone from the alveolar crest to the inferior alveolar nerve. You don't want to place those posterior implants most of the time at the time you extract the teeth. You want to give the bone probably 6 months to heal before placing the implant in the posterior area to be sure that the bone is good and solid and healed and you have enough vertical bone. You're probably not going to place it at the time you extract the tooth. The reason for that is the socket is too large and you've grafted the socket with bone graft and or PRF, and it's not solid enough because you don't want to put the implant through the apex of the socket because you don't want to get into the inferior alveolar nerve. That's the main thing in the mandible, is you don't want to damage the inferior alveolar nerve. Now you cannot place an implant most of the time in the posterior part of the maxilla because the sinuses are in the posterior part of the maxilla and there's not enough bone. So the implant would not be stable if you placed it into the sinus. So this is where we started. You can see in the end I've placed these implants I've added the posterior implants. I had these 4 and I added one here and added one there in the first molar area. So I've added this one and this one, but before you place those, you want to be sure you take a periapical radiograph and measure with your measuring application on your computer to be sure you've got enough vertical space for the small diameter implant in the posterior part of the mandible, and you're not going to affect the inferior alveolar nerve. Now remember, the nice thing about a small diameter implant versus a root form implant is with a root form implant you have to drill all the way to depth. With a small diameter implant, all you've got to do is pierce the cortical bone, and then the implant will bite and draw itself into the medullary or trabecular bone. So you don't have to drill to depth with a small diameter implant, which is much more predictable and safer in the area of the inferior alveolar nerve, because you don't want to damage the inferior alveolar nerve. We've already placed the implants in the anterior part of the mandible. So the denture was not as stable as the patient would like it to be. It's 100 times more stable than a regular denture without implants. As I said, I don't do dentures without small diameter implants because I don't want to mess with that. They're too unstable in my hands. Now, you may be able to make a denture without implants and make it stable. I can't do it. So they're going to be 100 times better with small diameter implants stabilizing them than they would be with a plain denture. But if you want to make it a little more stable, you can place implants in the posterior part of the mandible, and that's what we're adding right now. So this patient has had the denture and he's had the implants placed in the anterior part of the mandible, and now he's had the denture, and all this has gone on for about 6 months. And so we're going to try to make it a little more stable with the implants in the posterior part of the mandible. So this is just local anesthesia. You can watch the video on how to provide painless and profound mandibular or maxillary local anesthesia. So this is where I'm starting. This is on the left side, and you can see I've got from the alveolar crest to the inferior alveolar nerve, I've got 11.85 millimeters, which means I could easily place a 10 millimeter small diameter implant in that area. So I'm going to wipe the soft tissue with Paragard. Now I'm not going to drill all the way to 10 millimeters. I've only got to drill probably 4 or 5 millimeters. And then I'll let the implant bite, carry itself. See, now this is about 4.5 millimeters, 4.5 or 5, what is it? 4.87 millimeters here. Or this is about 4.5 millimeters, and from here to the inferior alveolar nerve is another almost 5 millimeters. So I know I'm good for about a 10 millimeter implant. So this is a 10 millimeter, 2.5 in diameter millimeters small diameter implant. I've only drilled to about 4 millimeters, and then I'm going to let it carry itself, bite, and screw itself in to 10 millimeters. So if you were, worst case, if you were to touch the nerve or touch the inferior alveolar nerve canal, it might displace the nerve a little bit, but it's not going to damage it. It's not going to cut it like it would if you were drilling to depth with, as you have to do in a root form, with a root form implant. I want to be sure it's aligned correctly, and then I'm going to use the finger driver as far as it will go, and it'll get to a point that you can't screw it in anymore. Then I'm going to use the ratchet wrench. Now I'm using this rather than the T-wrench or the winged wrench because you don't have enough vertical space to get the winged wrench in the posterior part of the mouth. I'm going to screw this to depth. I want the shoulder on the implant to be right at the gingival line, and I'm going to test it with the finger driver. I shouldn't be able to screw it in any further with this finger driver, and if you can't screw it in with the finger driver, you know you've got a good stable implant, and the chance of success is about 95%. So see, you can see the shoulder is right at the level of the gingival tissue, and here's the implant. You know, this is the superior border of the inferior alveolar nerve. The thing you don't know is on the lingual part of the mandible. So this is just fine. Now this is the right side. See, I've got almost 13 millimeters between the alveolar crest and the inferior alveolar nerve. So we're going to do the same thing over here. Wipe the tissue with Paragard. You could wipe it without isopropyl alcohol. And I saw the distance from the existing implant back is about 13 millimeters. So I'm going to measure from the existing implant to the position where I want to place the implant I'm placing. I'm going to mark it. Then I just took that radiograph with my applicator on my computer and measured from the distal of the most distal existing implant back to a level of good solid vertical bone, where the height was right, and that's where I'm going to place this. The further back you can place them, the better, the more stable the denture. So I'd like to place it in the area of the first molar tooth. If you extracted that tooth, you don't want to place an implant there for at least 6 months. You want the bone to heal so the bone is good and solid, and it'll take about 6 months for those posterior teeth that have been grafted to heal completely. So I'm going to pierce the cortical plate, probably drill 4 millimeters, take a radiograph. So I'm about 4 millimeters in, and I've got almost 5 millimeters from the tip of the pilot drill to the inferior alveolar nerve. So again, this is going to be another 10 millimeter 2.5 small diameter implant. I use 2.5 in diameter small diameter implants for both the maxilla and the mandible. Now for the maxilla, a 2.9 millimeter diameter implant is ideal, but it's hard to find those, and so the company I'm working with only makes 2.5 and 2.0, so I use 2.5 for the mandible and the maxilla when I'm using small diameter implants. And then the length will vary. So I'm doing the same thing. I'm screwing it in with the finger driver, then use the ratchet wrench. And I'm going to screw it in till the shoulder is right at the gingival line. The shoulder is right here at the bottom of the driver. You don't have to worry about burning the bone with this. You can't turn it fast enough to burn the bone. See, so it's right, the shoulder is level with the gingival tissue. And here it is, here's the inferior alveolar nerve, so that's just perfect. These are the new implants, these are the existing 4 implants. I've done this about 4 or 5 times on patients, and I may start doing it on every patient if they've got enough vertical bone. The thing is, you can't do it at the time you extract the teeth. If you have to remove molar teeth, you have to wait 6 months to place these. So you're waiting 3 months to start fabricating the denture, so you'd have to wait another 3 months to place these posterior implants. So I'm going to show you what you do then once you've placed them. You can go ahead and load them at the time. So because there was a little bit of movement in the denture, I'm going to also show you how to reline a denture with hard reline material. So you first place these shims. These are the new implants I've just placed in the posterior. You want to be sure to block out the apical part of the coronal part of that implant. Otherwise, if you lock that hard acrylic reline on that implant, you will not have a good day. You'll have to cut the denture off. So be sure you use those shims if you're relining or if you're pulling a housing, and be sure that shim goes all the way down to the gingival tissue. You don't want that hard liner to get underneath it, or it'll lock in and you'll have to cut that denture off. So I'm going to pull housings on all of the implants. Now what I'm trying to show you in these dentures is not dental school. This is real practice. And if you process these housings in the lab and you ever have a denture that rocks, sometimes it's very difficult to figure out which implant it's rocking on. I probably haven't had to do this twice in 20 years plus of making small diameter implant supported dentures. But if you ever do have a denture that's rocking, don't mess around with it. Just go ahead and remove the housings, make large holes in the denture like I'm going to do, and pull the housings with a hard reline material. I'll show you how to do that. But when you're pulling a housing in the office, I'm going to say this about 10 times. Be sure you put a green shim under the housing, between the housing and the bottom of the implant, because if that hard liner gets on that part of the implant, you are going to have a bad day. You're going to have to cut that denture off to get it out of the mouth. So you want these shims to be a little longer than they need to be, so the housing compresses it into the tissue just a little bit. You want it solid against that soft tissue. So you can see they're a little bit long, but the housing will squish it down into that tissue. What is that saying? An ounce of prevention is worth a pound of cure. Taking the time to get these housings and shims correct will save you hours of having to cut a denture off and remake it. So be sure you get this right. Now I'm going to check to be sure that the housings aren't touching the denture. So I've cut the old housings out and I'm putting this to place, and I want to be sure none of that white paste is touching the housing. See, these are the new implants back here, and you can see where I've cut the old housings out. Now when you cut them out, be sure you make the holes larger than the housing. You do not want the housing touching the sides of the denture. It may torque it. You want to be sure you've got more space than you need for the housing. So I'm cutting the new holes for the new implants, and that white paste marks where the top of the housing is, and now I'm making this hole larger to be sure the housing does not contact the side of the denture or the top of the denture. You want it to be loose or have open space around it in the denture, and push it to place and be sure it doesn't rotate or doesn't rock. So I like to do this with the housing on the implants to be sure I've got enough space, because the housing is going to be on obviously whenever you place the reliner in the hard reline in the denture. So I'm going to check it again with that white pressure paste. You push it to place, just be sure nothing touches. Give yourself plenty of space. You want to overdo rather than underdo, and I don't want to take any chances on that housing hitting the denture. So you clean it real well, and then you wipe this adhesive in the area where you're going to reline the denture or pull the housing. Now since I'm doing it, I'm going to go ahead and reline the whole denture. So I'm going to roughen the parts of the denture where there are no implants, clean that, wipe that real well with water, and then I'm going to place this adhesive all the way back to here, and so I get a good stable reline. Put Vaseline on the parts of the denture that you don't want the hard reline material to stick to. Then this is Jewel Cure Hard. I like this real well. And just squirt it in the holes you made in the underside of the denture. Keep the tip in the material so you don't get voids. And I'm going to squirt this all the way back on this part because I want a good stable denture. I don't want it to rock. Now pulling the housings in the office is the most accurate way to get perfectly pulled or set housings. If you process them in the lab, there's a little tiny potential for one of the housings to be off just a little bit. 99% of the time they're fine, but if there's a little rock in the denture, oftentimes you've got to remove all the housings and do what I'm doing right here. So this is a good thing to have in your bag of tricks just so you can use it if that ever occurred. I pushed it to place, popping it out. Now, if you didn't have those shims on there and that hard reline material got on that implant, you're not going to be able to get it out. It's going to lock in. So here we are. And I'm going to adjust this with a Brasileir acrylic burr. Just cut the excess off. Be sure you don't have any undercuts. Nice thing is you're not depending on the tissue to hold the denture. You are depending on the tissue to support the denture. When you press the denture down or when the patient bites on the denture, you want it to go to place against the soft tissue. If you've got the denture fulcruming or contacting hard on an implant, they'll fracture it right there. It's a fracture point. So be sure the denture is supported by the soft tissue, even if you've got small diameter implants. The small diameter implants are going to keep the denture from rising up and coming out of the mouth, but they're not going to support it when the patient's biting down. That should be on soft tissue. To get rid of any undercuts, then polish it with pumice and water on a rag wheel. Then look at it from the bottom, be sure there aren't any undercuts. Then I'm going to scrub it again with pumice and water. I'm going to brush, make sure all the little pieces are out. Then the patient pushing it to place, bite it hard. Then check the patient's bite occlusion. Be sure he's contacting on both sides at the same time when he bites down. And then here's the implant on the left. Here's the implant on the right. There's the implant on the right, the left. And we had these 4 were placed originally. So he has been a very happy camper since we did that. Like I said, I may start just building this into my program. And the way the program would go is you take out the teeth, you place an upper immediate denture only, not a lower. You don't place the implants at the time. You graft the sockets with PRF and or bone graft material and collagen resorbable membrane. Let that heal for 3 months. Then place the implants in the mandibular anterior and the maxillary anterior. Let that heal for 3 months. Then I would consider coming back and placing 2 more implants in the mandibular posterior if I really want to stabilize that denture. And go ahead and take the impressions, the impression for the custom tray at that appointment, because it's going to take about 6 weeks to fabricate the final denture. So you're placing the implants in the posterior mandible after the teeth have been extracted for 6 months. And like I said, I may start adding this to my method and just incorporating that into the process. So that's the Dental Minute. These techniques work, and they work every time.